This is Karen Anderson. She's an associate professor in Biodesign Institute and also in SOLS, right, School of Life Sciences. She got her undergraduate degree from University of Virginia, and then we were talking about, that's the #1 party school now. So despite that, she went on for an MD and PhD.
ASU?
ASU is not even in the top 10.
Oh, wow.
What? According to Playboy magazine, actually.
We'll have to change that.
So she's an MD, PhD from Duke, and spent a number of years up in Boston at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute. She came down to ASU in 2011, and she's here. So she's going to talk to us today about using proteomics to identify immune response biomarkers for the early detection of cancer.
Great. So, thank you. And can you hear me? I'm not sure if this is working. Good. So this title is not exactly the title we were talking about, but we have been working for a number of years, and my laboratory has been interested in how the immune system sees cancer, and in particular for solid tumors, and what we can learn about how the immune system sees cancer, how we can exploit that both for the early detection of cancers and also for immune therapy, and how we can measure the variation in the immune responses to cancer to help design better immunotherapies. And so I'm going to be talking about sort of those two halves really of my work. The main thing about cancer, this is a photomicrograph of a breast cancer tissue from actually one of our patients. And if you're not used to looking at these are tumor cells. These blue things here are her breast cancer tumor cells. And these tiny little blue spots in here are lymphocytes. These are the immune cells that are sitting up against and sort of intercalated with the tumor cells. And this is actually occurring naturally in this particular patient. And in 50% of HER2-positive breast cancers, it's a subtype of breast cancer, 50% of them have this type of dense immune infiltration. And what this means, what it does, how it affects patients, we don't really know. What we know is that if you grind up this tissue and you look by RNA at those who have infiltration and those who don't, for this particular type of cancer, those who have infiltration do a whole lot better in terms of disease-free and overall survival. But why and what components within here actually affect that, we don't really understand. The thing about the immune system and anti-tumor immunity is it really is a balancing act. So there are many different components of the immune system, and so we talk about inflammation and non-specific inflammation actually being tumorigenic. So it helps promote cancer growth. And there is extensive amount of data on this in a variety of different solid tumors. So people who are prone to getting inflammation, and there are many ways you can be prone to getting inflammation, are more likely to get cancers. And if you look at inflammatory biomarkers, common one people look at is IL-6. If you look at anti-inflammatory biomarkers, IL-10, a number of different cytokines and chemokines that are themselves biomarkers of inflammation. These things tend to correlate with whether people's risk of getting cancer and how they're going to do if they get cancer. So in terms of clinical outcomes if you're diagnosed with cancer. And so inflammation itself is thought to be, in many ways, tumorigenic locally. So if you have chronic inflammation, H. pylori is a classic example of this. If you are infected with a bacteria called H. pylori in your gut, you have a much higher increased risk of getting gastric cancer. And eradication of that infection with antibiotics has profoundly changed the incidence rates, or I don't know if it's changing the incidence rates, but we predict it will, of gastric cancer. And so that is a standard treatment to prevent gastric cancer, and it cuts down on that infection, which causes local irritation and inflammation in the lining of the stomach. And so local inflammation appears to be tumorigenic, but also we know that the immune system can fight cancer. We know this from a number of different mouse models. We know this in the setting of risk of getting cancers in patients who are immunosuppressed. In particular, viral-associated cancers like human papillomavirus. Immunosuppressed patients like HIV-infected patients are at increased risk of papillomaviral infections. Epstein-Barr viral lymphomas are associated with immune suppression. So if you suppress the immune system somewhat specifically, you can have increased risk of getting cancers in certain cancer types. So there appears to be this balancing act between effective immune control and what we call immune imprinting, so that that there is this continual immunologic pressure on cancers as they develop. So the cancers that end up developing are in the setting of an immune response is different than the cancers that develop without. And there is this continual immunologic pressure on the tumor cells to evade the immune response. And so we have both tumorigenic components. We have B-cell activation. We have specific targets. We have ways to get the immune cells to the tumor. We have innate immune responses, the most sort of fundamental primitive immune responses that we have to cause effective immune responses. And then we have all of these things that the tumors can do to evade those immune responses that they develop in the setting of a healthy immune reaction. And because there are all of these different components, the analysis and identification of different targets and the immune response to these and how we monitor these over time are really just, you know, in the early days of development, you have to be able to measure a very broad number of things, and you have to understand how to analyze these. And this is something that Garrick has been interested in for a number of years. We've been interested in a number of years from a wet lab perspective. So the primary model system I'm going to talk about today is breast cancer. I'm going to talk some about ovarian cancer and a little bit about human papillomavirus. But this is going to be the primary system. I am a breast cancer medical oncologist. I actually practice here at Mayo a day a week. And this is there are many reasons to study breast cancer immunity. But one of them is that this is a common cancer. It affects, you know, roughly 40,000 deaths in the U.S. a year. Effective therapy is limited by the fundamental heterogeneity of this cancer. So there is fundamental genetic heterogeneity. This hit the news this week, since some of the TCGA sequencing data was published on Monday. It's in Nature. And a number of other studies have come out in the last couple of months demonstrating some of the genetic heterogeneity. I'm going to show you some of our analyses of these. But it is a common cancer. It is a relatively, not all types of breast cancers, but many of them are relatively indolent compared to a leukemia, for example, compared to a high-grade lymphoma. You know, breast cancer can be, certainly estrogen receptor positive cancers can be indolent. And so there can be years after diagnosis and surgery where patients have what we call minimal residual disease, where they likely have dormant tumor cells, especially in their bone marrow, that recur after 5 years or 10 years. And one of the challenges in treating breast cancer is we never get to say after somebody's had surgery and all of their treatment that you are cured, because we do see relapses and we do see them late. And how that works and the mechanism of that and how much of that is under immune control, which we think a good bit of it is, does at least give us a window of opportunity to give immune therapy to these patients. And recently, from an immune therapy standpoint, there have been approval of a number of different immune therapy drugs by the FDA for solid tumors. And one of them is the prostate cancer vaccine called Provenge, which was approved last year for men with advanced prostate cancer. It is not a cheap treatment, roughly $30-some thousand per treatment for 4 treatments. But head-to-head was superior to a selected chemotherapy. So this is nothing but a vaccine. And also the FDA approval of ipilimumab, which is an immune activating drug for melanoma last year. So, and there are a number of different phase 2 vaccine trials that are currently ongoing in breast cancers, melanoma, lung cancers, prostate cancers, and others. So if you're going to design a breast cancer vaccine and you want to think, okay, informatically, how do we identify what would be a good target? You know, we always talk about targeted therapeutics. Well, vaccines are no different, okay? How can you do a targeted therapy? When I'm talking about vaccines, I'm not talking so much about prevention, I'm talking about therapy. So it's really immune therapy. They could potentially be used for prevention, but it's much harder to figure out whether or not they work. It takes much larger trials. So we're really talking about, in breast cancer, women who have been diagnosed with cancer, have been treated, and are at risk for recurrence. And so really targeting those women. And so we have looked, my laboratory and the groups I've worked with over a number of years, both at Dana-Farber and here, have looked at a number of different breast cancer tumor antigens. And so many of these have been identified. So these are proteins that are overexpressed in cancer. And these proteins that are overexpressed in cancer can be a number of different categories, if you will. So they could be chimeric molecules. They could be differentiation molecules. They could show up as the cancer develops. They could be specifically mutated. I'm going to talk about some of these in particular, especially as we learn more about the genomics of cancers. Are there ways to target those that are mutated specifically? It gets hard. We had focused on ones that are strongly overexpressed over the years. These are a number of the ones that I've been particularly interested in. Cytochrome P451B1 is a protein. Human telomerase is an enzyme that has been used in clinical trials. It's been used in a nucleic acid DNA vaccine trial. We have worked with some mouse studies on tumor protein D52, which is strongly overexpressed in breast and prostate cancers. We have been involved with some of those. Prostate-derived ETS factor is also in breast cancer. And P53, which is one of my favorite molecules as we think about cancer vaccines, which is mutated in a large number of cancers and in about 25% of breast cancers. And then there are a variety of others. So, but if you look at breast cancer is not one disease, it's many. And if there is one thing you're going to learn about cancers, it's about heterogeneity and the issues of heterogeneity. So Jay Park, who has been working in the Center for Personalized Diagnostics in our center at Biodesign Institute, has done some data analysis of the TCGA, or the Cancer Genome Atlas, data sets of about 500 breast cancers. All right, they underwent exome sequencing. And if you look at the somatic mutations in these 500 cancers, and they had to be cancers, breast cancers, that were large enough where there was enough tissue to be able to do this. So it is a somewhat skewed population of cancers, but still there are many different, 4 different subtypes are clearly represented within that set. And when Jay looked to say, okay, if we look at what are the common mutations that we see in at least 3 out of those 500 cancers, and what is the co-mutation network, what mutations happen together to understand what happens in breast cancer? Well, P53 is far and away the most commonly mutated antigen in breast cancer. But the challenge with P53 is the things that are co-mutated with it are all over the map. And so if you want to say, okay, I want to target P53 mutations, well, there's about 200 different non-synonymous coding P53 mutations that occur in cancers. Now, the common types do overlap between breast and ovarian cancers and between certain adenocarcinomas. And so one could target these, but any given mutation, R175H, arginine to histidine, non-synonymous mutation at 175, that's the most common one for a number of different solid tumors, but it's still only 5 to 10% of the P53 mutant cancers, which are 25% of breast cancers. They are the high-grade cancers. They are the cancers associated with mortality. They are the ones that you really want to target. But the challenge is a specific mutation is a rare event. And if you're looking at a population of 40,000 women who are dying of cancer, and 25% of them have mutations, and 5% of those are going to have R175H, you're dealing with a smaller numbers of patients. This is the challenge of personalized medicine. And how do we design a therapy or an immune therapy, whether it's a targeted therapy or an immune therapy, to something to which there are not a lot of patients in a given category. As we keep dividing and subdividing patients, this is the challenge. How do you design a clinical trial to see if it works? How are we going to design 200 different P53 targeted vaccines for these mutations? It's hard to do. And how do you measure the immune response to all of this variation, this genetic variation within these tumors? So in breast cancer, not only do we have P53, but we also have PI3 kinase is also commonly mutated, and you can see a number of others that have shown up here. And if we try to look at this and line this up based on RNA expression, so how do these mutations correlate with a typical expression array signature? RNA expression array signature, in this case the PAM50 expression. There were about 50 cases within this data set which had in common mutation data and also had expression data. And so within these, and breast cancers can be divided into a number of different types, and here we'll just call these basal and luminal based on hormone receptor expression, estrogen and progesterone receptor expression, and ERBB2 expression. So ER and PR negative are the basal. Basically, these are the what we call triple negative breast cancers. You'll hear that term a lot. Luminals tend to be hormone receptor positive. But as you can see here, P53 mutations and PI3 kinase mutations tend to occur in different populations of tumors. So there's not a lot of overlap. There is some. Some will have both, but there's not a lot of overlap between those. And this has been really presented in much more detail by the recent TCGA papers that I'll refer you to. But if we look at, okay, well maybe you've got a whole bunch of different individual mutations, but maybe there are specific pathways that we could go after. Whether or not this is targeted therapy or immune therapy, maybe there are different pathways. And so we have worked to identify some of these targeted pathways, at least from the TCGA data sets, okay, of what pathways might be in common. And the nice thing is that a lot of these are the ones that you would already expect. So at least that the data is consistent with what we had already known biologically and clinically as potential pathways involved. BRCA1, RB1, P10, PI3 kinase, P53, ERBB2, a lot of AKT, a lot of these had already been known. And so you can see that these start to coalesce into nodes. So while you might have many different individual mutations, they tend to fall into common pathways. And exploring the functional consequences of interrupting these pathways is the focus of a lot of people's research, including ours. But so the real challenge is how specific does immune therapy need to be? So do we go after individually mutated P53s, or do we try to take a step back and say, well, maybe we're overthinking the problem, and what we really need to do is to vaccinate against a variety of different types of tumor antigens. And in particular, since the immune system is continually putting immunologic pressure on tumor cells, can we actually vaccinate against the cells themselves? And so what I would call sort of the non-specific version of vaccines would be a cellular-based vaccine using patients' own tumor cells as the vaccine. And so that's actually what we had started with. And so the term for this is GVAX, and the vaccine trials, and there's two clinical trials that are now completed that I was involved with at Dana-Farber, have been these autologous cellular-based cancer vaccine trials. And we really did this, we started these in part because if you don't know what the best targets are, the question is, should you vaccinate to a number of different things and then narrow that down as you learn from those initial vaccines. And because we recognize that these tumors are very, very heterogeneous. And so trying to overthink that and doing a very specific target where tumors can develop resistance is difficult. So Glenn Dranoff at the Farber had done a number of mouse studies back in the 90s saying, okay, if we try to vaccinate against cells, in particular melanomas where he started this, how do we boost the immune response to a given tumor cell? So what he had found was if he put in a gene for encoding GM-CSF, GM-CSF is a cytokine. That's a hormone in your body that activates your immune system, that your body naturally makes. Granulocyte monocyte colony stimulating factor, GM-CSF. It is actually a drug that is used clinically to boost immune responses, and it is a cousin to G-CSF or Neulasta that we use every day in the clinic. So he found that if he put the gene for GM-CSF into tumor cells to rev them up, essentially to activate the immune response, irradiated them so they weren't going to grow, and inject them under the skin in mice, that they can prevent the development of melanoma and lung cancers in a variety of different models. And what he had shown was that this effect, this was far and away the best cytokine that worked, and it seemed to cause this recruitment of immune cells, and then you get apoptosis and dying tumor cells, you get processing of antigens, you get activation of T's and B cells, which then go on and lyse tumor cells in the other parts. Okay. It seems very inexact. It seems very inelegant, but it worked in the mice. And so what Glenn and a number of others, and Steve Hody and Ravi Salgia have done in a variety of different tumor types was to say, okay, will this work in patients? It's the ultimate personalized vaccine because they're taking patients' own tumor cells to do this. It is technically complicated because you have to harvest tumor cells, you have to keep them sterile, you have to process them in very specialized laboratories, and you have to irradiate the heck out of them so that they will not grow. And then they are injected back in the skin of patients as a vaccine. And so in a number of different clinical studies, mostly phase 1 clinical trials, this had been done, and it's shown that a minority of patients seem to develop clinically important immune responses. Minority being less than 10%, I would say. Develop some amount of immune response and tumor response that we could measure in these patients with advanced melanoma, lung cancer, and I'm going to give you an example of ovarian cancer. And this was an example of, which really points out a number of important things. So this was a patient with ovarian cancer. She had advanced ovarian cancer, and she was, we know from ovarian cancer has a biomarker called CA-125 that is elevated in women with advanced ovarian cancer. And when they get vaccine, you end up, this woman actually got vaccine, and her biomarker didn't seem to do very much, but then she got boosted with a drug called anti-CTLA-4, also known as ipilimumab. What you need to know is it activates the immune response non-specifically, just wakes up all your T cells. And so when she got this drug, her biomarker suddenly plummeted. And then eventually it started to go back up, and each time with one of these black arrows, she got another dose of this immune activating drug. This is one of the clearest examples that we had that you can use the immune system, you can harness the immune system to control a tumor, a solid tumor, an ovarian cancer. And whether or not the vaccine here helped prime, we think this helps prime and this helps boost an immune response. In the same way that you get multiple vaccines to infectious agents, essentially we're getting multiple vaccines to prime and boost an immune response here. And this occurs, though, over many years, 2003 to 2006 here. So the other thing it illustrates is that having effective anti-tumor immunity takes time. And these principles are important because when it comes to figuring out what these patients are responding to, that's really the challenge. And how we figure out the kinetics of an immune response, how do we informatically look at this question, is really a really important part of how we measure these things. So I'm just going to go through a little bit about what we did in breast cancer till I get to actually how we think about these target antigens. So we did this in a small clinical trial, phase 1 clinical trial in advanced breast cancers, where we took women, 12 women with advanced breast cancers, we harvested their tumor cells. Their tumor cells were infected with a replication defective adenovirus encoding GM-CSF. It seems like a complicated way to give a drug that is already, you could just give as an injection, as a recombinant protein. But for some reason, and we don't understand, it only works if you give the gene and not if you give the drug next door to it. I don't understand, but it is important for the tumor cells to produce that GM-CSF in terms of immune activation. It makes it much more complicated because it becomes a gene therapy trial. But the cells are irradiated, and this is the vaccine. And so in different doses are given based on how much we harvest. And we vaccinate weekly for 3 weeks and then every other week until the vaccines are done. And we do this immune monitoring. And as I showed you, some of the immune responses that we see to, in that previous slide, happen over years. But here we're measuring immune responses monthly and then every other month. I'm going to show you some of this. So in this case, we successfully made tumor cells. We were successfully able to process them. They were viable. They uptake the virus. They produced GM-CSF. We were able to irradiate them. We had different dose levels. This is really what this gets at. And the 12 women who actually received vaccine had all had metastatic breast cancer, had all had prior chemotherapies. They were all refractory to their chemotherapies. So they were fairly heavily pretreated. We think about how many prior chemotherapies had they had for metastatic disease, almost an average of 3. So these were fairly advanced patients. And it was a mix of different tumor subtypes, either hormone receptor positive or HER2 positive. And out of those 12 patients, we had 3 patients with some number of months of evidence of stable disease using modified RECIST criteria, and 1 patient who was rendered with no evidence of disease at the time of surgery when we harvested her metastatic tumor, who has now been alive in NED for a couple of years. Again, we don't know whether that's related to vaccine or not. But what we do see is these things are very well tolerated. Over 1,000 doses have been given of a variety of different autologous tumor vaccines over the years. And they have some number under 10, I believe, of long-term survivors on a combined numbers of studies with no evidence of long-term toxicity. In general, patients get injection site reactions. Nobody's landed in the hospital from these vaccines that I know of. Certainly not from this patient population. So they get tired and it feels like they have the flu, and their white counts change a little bit. And they get some local skin site reactions. But the challenge is, how do we know if it's working? So one can look at survival. You can't look at survival on a small phase 1 clinical trial. You can't look at this because we don't know. But what we can say is that for some number of months out, we've had a few patients who have been alive, most with disease, and 1 without disease. But how do you monitor something complex? And I can tell you that there are a number of different targeted immune therapies that are working their way through cancer therapies right now. And vaccines, infectious disease, everything else. PD-1 is a target, as well as CTLA-4. A number of different companies are developing antibodies. So how do you measure this? So what we know about the breast cancer vaccine, this is a sort of a picture of what it looks like on someone's leg, and you get this sort of this big red swollen area about 2 days after vaccine. If you've ever had a TB shot, TB test, and you know how they look at it 2 days later, we call this a delayed type hypersensitivity reaction, or DTH. Your T-cell immunity happens takes about 2 days to kind of kick in and to get there and to cause that inflammation locally. And so we can measure this, and literally we put up a ruler and we measure this, and if you measure the erythema, we can graph it out, what happens to patients. We did skin biopsies at baseline and then after 5 vaccines to ask what was this inflammation, and so we can see this inflammation in the skin biopsy, both in vaccine sites, but we also did, the problem with a vaccine site is that we have a hormone in there, which is designed to cause an immune response, so it's really hard to tell what's to the tumor and what's just to the hormone. And so we look at unmodified tumor cells that are irradiated, so a small dose of unmodified tumor cells, and we ask, do you get inflammation to those? And the answer is we do. And if you actually look at a simple measure, erythema, how big is that red spot at the site of the vaccine? When we start the vaccines, nobody has reaction to their tumor cells, and after 5 vaccines, the majority of patients develop immune reactions to their unmodified tumor cells. So we seem to be getting a local skin site reaction to unmodified tumor cells with these vaccines. We had 1 patient develop inflammation at multiple tumor sites post-vaccine, and we had 1 patient in whom we actually obtained biopsies of a cervical lymph node before and after vaccination. She was on nothing but vaccine for about 10 months. And so she was vaccinated at baseline, and she was biopsied after about 10 months. And we looked for infiltration of immune cells into the tumor site. And so these, you can't really tell here, but this sort of dark area here is what we call tumor nests. And these dark areas are tumor nests, and they're stained for a T-cell population called CD8 positive T-cells. It's an indirect measure. We see this infiltration. We don't know what they're doing. We don't know what they're hitting. We don't know whether or not these are having a functional effect. But it's a hint that the vaccine may be causing a local immune response to tumors. Now, if you want to know what they're targeting, because ultimately we don't want to be vaccinating against a whole tumor cell. Essentially, you're vaccinating against the entire proteome. You run the risk of developing autoimmunity to this. So ultimately, we want to know what we're hitting so we can design the next generation vaccines that are more focused. All right. And so to ask those questions, if we want to ask what are the T cells seeing, this is really hard. And this is where the science comes in. So we can predict what those T cells might react to. So we have 4 patients out of those 12 who are HLA-A2 positive. It's a 50% estimated frequency in North America. And so out of those A2 positive patients, we can predict these epitopes based on the literature, based on what other people have seen, for a number of different tumor antigens, both known antigens and novel antigens that we had identified. And if we look for T cell immunity at baseline at 1 month, at 2 months, these are in duplicate, and these little blue spots here, each one represents a T cell that is activated. It's secreting interferon gamma. So it's something called an Ellie spot. So we can see to this particular epitope, which we had predicted to one of my favorite proteins, TPD52, this particular epitope was immunogenic. This survivin epitope was not. This survivin epitope was. And so we can start to see that there are multiple immune responses, but it varies from patient to patient. So the ones here with the arrows, we did detect some amount of T cell responses to, but it is not a proteome-wide measurement. We have no way at this point to measure immune responses across the proteome, much less the mutational proteome, much less, splice variants, fusions, and all of the other neoantigens that may happen with cancer, much less the antigens that are developmentally regulated in cancers. So we're really just, what do we have here, 11, 12? 12 peptide epitopes out of, tens of thousands, hundreds of thousands, potential ones that exist. We're not even at the surface yet, much less, getting any sort of comprehensive measure of what the T cell immunity is. And the techniques don't exist yet. We can look for things we can predict, but we can't look across the board. And I think it's a real challenge. And so, out of this, what we learned, and I'm going to talk about how we go after B cells in a minute. But what we learned is that, these sorts of vaccines, they're very well tolerated. We don't know if they work yet. We were vaccinated for women who were at very advanced disease. And then, so the high risk, we went to a high-risk adjuvant clinical trial, which is actually now closed. We had a lot of issues with this in terms of having sufficient tumor cells to be able to vaccinate. I don't think this is something we can take to a randomized phase 2, because just the logistics of getting enough tumor cells to be able to do this. But the primary limitation, I would say, was being able to measure the immune responses. I'm going to talk about 2 things. 2 approaches really that we're taking, and I just want to sort of mention this. This actually is out in today's New England Journal of Medicine from today, a very intriguing way to culture and to expand primary tumor cells that I think there are a number of different methods that are being developed, but believe it or not, it's very, very hard to grow primary breast cells. You can't just take those cells out and try to expand them. We can't get enough from a primary breast cancer to be able to do these kinds of vaccine studies on anybody who has a small cancer. And so you need to be able to expand them in vitro, and one of the ways we're expanding them in vitro is using this, it's a special feeder cell system that was developed by Dick Schlegel's group at Georgetown. And this is one of several methods of doing this, but I think that this provides an opportunity to be able to expand cells out, to be able to make cellular vaccines if we choose to go that route. And these cells actually can be grown in culture. We can compare normal and cancer from the same patient, so same genetic background. So an isogenic background, we can look for the specific changes that happen in the carcinomas. And this really just shows that these types of primary cells seem to maintain phenotypic, and we're not sure about the genotypic fidelity, but certainly phenotypic fidelity of the difference between a normal breast epithelial cell and a cancer-based epithelial cell, both in vivo model systems and also in 3-dimensional culture systems. So we are working on ways with Peter Cohen here one of these buildings here, to think about how can we develop second-generation vaccines that might be more clinically feasible. And I think this remains to be seen. But I think that one of the things that comes out of this and across the whole field of tumor immunology is we really need to think about systems immunology the way we think about systems biology. We need to be able to measure things across the entire proteome. The simple question of, out of your 25, 30,000 proteins, we're not even going to think about post-translational modifications or splice variants or mutations or anything else, but just your baseline ESTs. How many of these gender immune responses, just in healthy people walking around, what is your immune system seeing? And of those, how many of what's being seen by your T cells and what's being seen by your B cells, and what is the frequency of these in the general population, in patients at risk for certain disease, in patients who have certain diseases, and patients who are treated for certain diseases? What are the predictive, prognostic, and early diagnostic immune biomarkers? And to be able to ask those questions, you really need to measure it across the proteome. And I think that's really difficult to do. But we're getting closer to being able to do this with B cells because antibodies are easier to work with. And that's why you will see lots and lots of papers about B cells, not because they are more important, but because technically we can do them in ways that we can't do T cells yet. But what overlap? There is some overlap. B cell, immunogenic B cell antigens, clearly some subset of those also engender T cell responses. So people have looked, ourselves included, have looked for B cells to try to, as a way to get to the T cells that may be involved. But what is the degree of overlap? We don't even know that, just for healthy infections, much less anything else. And when you start to think about self-antigens and the complexity, it's difficult. And then factoring into this is innate immune response, is your immune genetics. What genetics are you bringing to the table that may influence your ability to respond to a given infection or cancer or both? And I put in here under immune education, one of the exciting and frustrating things about the immune system, it is adaptable. It alters. It alters based on all of the infections and organisms and microbiome and everything else that you have seen throughout your lifetime. And so how that education process affects your ability to respond to a given threat, insult, infection, cancer now, we don't fully understand because we don't have ways to measure both the immunogenetics or the immune education that has happened over a cumulative time. Because what we do know is that your T cells and your B cells do adapt. And they don't just adapt phenotypically, they adapt genotypically. They alter, they undergo somatic mutation, they undergo somatic rearrangement of their genomes, and to develop T cell receptors and B cell receptors under a completely committed path to target a certain things. I can tell you that if you look at chronic infections, T cells to chronic infections, a good amount of your T cells, maybe even 5% of your T cells, are committed to seeing Epstein-Barr virus, cytomegalovirus, and other chronic infections that we all walk around with and have, but that are kept at bay. In part, not we all, but about 95% of us have been exposed to EBV. And you have a significant antibody responses to these chronic infections. You have significant T cell responses to these infections. And that they're sort of kept at bay. But what role those play in terms of interfering with or promoting effective anti-tumor immunity, we don't really know. So, so our step one really was can we measure the B cells? I'll start with what we can do, and can we measure the B cells across the proteome, and how do we analyze that? And that's where you guys come in. So I'm going to start simple, and we'll work forward from there. And the simple one is to p53. So p53 happens to be the most immunogenic protein in cancer patients, I would say in general, ovarian cancer patients specifically. Far and away the most immunogenic protein that we have, and I don't know why it is so immunogenic, but it is. Probably because it's involved in the apoptotic pathway. But it is highly immunogenic. And then I'm going to talk about how we start to analyze multiple antigens. I'm going to use HPV as an example of that. And then we'll think about how we can apply these to protein arrays across the proteome and how we can analyze these. So if we're going to come back to p53 here, my favorite molecule, my second favorite molecule. HLA is my first. p53 is mutated. It's mutated at a lot of different residues. And it has this core DNA binding domain, and it's in this core domain that the most of these mutations happen. But the immunogenic regions are thought to be actually on the flanking ends of the molecule. And so we can make recombinant protein, p53 protein. We make wild-type protein. And those antibodies that develop in cancer patients cross-react with wild-type protein, or at least some of them do, the ones that we've looked at. So if you look at breast cancer patients, for example, these are healthy women, and these are women with increasing stages of breast cancer. And you can see a small subset, less than 10%, actually develop antibodies to p53. It's probably not a particularly good biomarker, these autoantibodies that happen for breast cancer, just because it's just not frequent enough. But breast cancer, and I won't go into this, but you only develop antibodies if your p53 is mutated. And because what happens when you mutate your p53 is you actually stabilize the molecule. So you have increased amounts of apparent p53 protein in patients who have these mutations. So you can, that's why you'll see, is it p53 positive tumor? Well, it's p53 positive because it doesn't degrade as much. So these same women who develop, some number of them develop antibodies to p53. If we do the same thing and we look for antibodies to an EBV protein, they all have antibodies, not all, 92% of them have antibodies to an EBV protein. So we know that their B-cell immunity is fine. It's not dependent on how advanced their cancer is. But it is a specific difference with increasing stages. And if we treat these women with neoadjuvant chemotherapy for HER2-positive breast cancer here, and this woman has an antibody to p53, and we treat her with an effective therapy, her antibody levels plummet over a period of several months with her tumor shrinking down. But antibodies to a control protein, EBV protein, don't change at all. So that this antibody response really is a biomarker of disease burden in these patients. And this is an important point as we think about biomarkers. Does it biologically correlate with disease? Is it associated with tumor burden? Is it associated with stage? Is it specifically associated with amounts of disease? And it appears to be that way. Do they go up before disease recurrence? We don't know. We don't know. But the way that we detect antibodies is there are many different ways to do this, and the way that we do this is to make proteins in real time. And forgive me for the proteomics component of this, but it's worthwhile to understand that we have cDNAs, we have DNA vectors that encode individual tumor antigens. And they are tagged so that we can track them and we can capture them and we can move them around. And we can express these in real time and we can capture them with anti-tag antibodies. And we make them with a mammalian extract, a human actually extracts, to try to mimic the protein structure that they have naturally. And so when you have these different target proteins, and then we make them, they can be captured with these anti-tag antibodies. We can detect the protein expression using this. And then you can have one protein over here, and we can add in serum, and we can say, okay, is there any antibodies from human serum that will stick to this protein? This is essentially an ELISA, okay? And we can do this on slides, and we can do this on beads, and we can do this in wells, or we can do this any which way. And this initial system of being able to express and capture these proteins was really optimized, and a lot of this has been optimized and developed in Josh Leber's lab in the CPD Center in Biodesign. And to explain how this works for p53 antibodies, I'm actually going to move to ovarian cancer for a minute because the frequencies are a lot higher, so we can actually ask meaningful questions about these antibodies as biomarkers. So in serous ovarian cancer, out of TCGA data, almost every single one has p53 mutations. The ones that don't have mutations probably have splice variants or early stop codons, so their p53 doesn't work. So in serous ovarian cancer, which is the worst kind of ovarian cancer, it's the one with the highest mortality rates, p53 appears to be a driver mutation. It appears to be an early event in ovarian cancer carcinogenesis. And there are all of these different known mutations, and this is sort of the structure of this. And so we had used this in vitro expression system to make recombinant p53. We compared it to how we measure antibodies in blood to p53 protein. And our way of making protein was kind of similar to making it in a test tube and then sticking it into a well. These are titrations. But one of the things you can see from these titrations is that when we think about antibodies in blood, so we can take the blood out to 1 to 1200 and we can still find these antibodies. So you can really dilute this stuff out. Serology and antibodies in particular, serology is the measure of antibodies in the blood, but serology, unlike a lot of other protein studies, we don't talk about quantity very much. We don't say there are a certain amount of picograms of material in the blood the way we think about other proteins. We talk about titrations. How dilute can you make this and still find a signal? That will change. It needs to change. It's not there yet. So we talk about dilutions as a measure of quantity. So I will tell you that in ovarian cancer patients, we can dilute this serum out 1 to 50,000 and still find these antibodies. There is a tremendous amount of antibodies in a subset of women with ovarian cancer that we can detect. And if we just simply take some case and control sera from women with stage 3-4 serous ovarian cancer, you can see here, we're looking at luminescence here, we can see these are control sera and these are case sera. You can see a significant percentage of women, 41.7% of these women, have strong antibody responses to wild-type p53 protein. And if you look at it as a bimodal, it really is a bimodal distribution. If empty bars are controls and filled bars are cases, you can see that cases develop this subset of cases, develop these sort of very bright amounts of antibodies, but the baseline is actually very comparable. So looks like we're dealing with similar sort of material, at least, between our case and control populations. And as we start to do biomarkers, you have to really know what samples you're dealing with. And in this case, we looked at women with serous ovarian cancers, we looked at non-serous cases, benign disease, and we looked at a lot of controls that were age and gender matched. These were obtained under standard collection procedures. They were obtained with the same tubes, and they were processed by the same people, and they were collected in similar ways in a similar region of the country, and this was all in New England, in the Boston area. And so we asked, well, if you're trying to do a biomarker study and you think this is a specific biomarker, what other things might affect your ability to measure this marker? And so, hence the detailed epidemiology, okay, for potential confounding variables. And so we looked at age, because the older you get, the more likely you are to get an autoimmune disease, so you want to make sure that your age and gender matched, which we were. You want to look for women, you want to look at menopausal status. You want to look at things that might relate to ovarian cancer generation. We looked at race. We looked at how old those samples have been sitting in the freezer. You want to make sure your controls have been sitting in the freezer as long as your cases, and that is often not the case. People will come back and collect the controls last year and they had the samples from 10 years ago, so you have to look at that. Length of storage. And the other thing with the year of specimen collection is that disease characteristics change in populations over time. Head and neck cancer is a classic example of this. We're getting more HPV-associated head and neck cancer and less smoking-related head and neck cancer. And so the biology of these tumors over the years is changing. And so what you have in the freezer may be different from 1999 to 2009. So we asked whether or not tumors had antibodies to p53, and like I said, we find about 42% of the serous cases have antibodies to p53. But the non-serous cases in benign ovarian disease actually has a background level about 10%. Yeah?
Was that in any dilution?
These were all consistent dilutions. These were about 1 to 300. Okay? And And so we do see some amount of background antibody staining. So we're looking at a difference of about 8 to 10% false positive rate to about 41% using these cutoffs. And the way we had done this was we had established cutoffs off of a training set, and then we did them on blinded validation sets to do this. And we looked at 2 other ovarian cancer biomarkers that are currently used in clinical use, CA-125 and HE4, which is a newer marker. These tend to track together in terms of disease. And so P53 antibodies and CA-125 and HE4 are all strongly correlated with serous ovarian cancers. And if one constructs ROC curves and asks cases versus controls or cases versus benign, in this particular sample set, which tended to be advanced cancer patients with ovarian cancer, HE4 and CA-125 actually were outstanding biomarkers. In clinical use, they are nowhere near this outstanding, okay? But in this particular sample set, they were extremely good. And P53, as I said, relatively lower sensitivity of detection. Not quite as specific as those other biomarkers. So do they have any additive value beyond CA-125 or HE4? And we looked at about 30 cases who had false negative CA-125 levels. So these were women who had advanced ovarian cancer but had negative CA-125s. They're actually fairly hard to come by, but they do exist. And when we retrospectively looked at those, we found about 30% of those patients had P53 antibodies. And one question is, so what happens kinetically? And this data is actually not published yet. What happens kinetically over time to these biomarkers? And we looked retrospectively at a blinded set of samples from the Risk of Ovarian Cancer Algorithm Study, or called ROCA. So these are women who, because of family history or other reasons, BRCA gene mutations otherwise, have a higher risk of ovarian cancer, and they underwent intensive screening. Every 3 months they were getting blood samples and tested for CA-125 levels. They were getting pelvic ultrasounds. You know, how do we screen for ovarian cancer when we don't have very good ways to screen? And so thousands of women have been enrolled in these studies, and out of those they had 9 women who developed ovarian cancers. And we tested those 9 women, 90 controls, and serial samples from those 9 women in blinded fashion. And so here, if you look at 2003 to 2007, so my x-axis is in years, and you're looking at this black bar is when they clinically were diagnosed with ovarian cancer. What you can see in this woman, her CA-125 levels in black start going up here in what Steve Skates calls a longitudinal change point. So at what time point do they actually change? So when you're looking and measuring over time, is it more useful to measure markers over time than it is to just check a one-time thing in the population? I think it depends on what marker you're looking at. But the longitudinal change point, when he goes back and looks at these numbers, is around 9 months before diagnosis. And P53 antibodies actually change in roughly the same amount of time frame. So they do go up prior to clinical diagnosis in 2 patients that we had. This is just an example of one of them. This is an example of a control, another case in which we don't see any changes, and this is an example of 2 controls that were matched to those patients, so you can sort of see how they vary. But the reason why CA-125 is not used in the general population is because it has false positives. And what do you do with a false positive for a biomarker for cancer, especially when the treatment is oophorectomy? This is the challenge. It is a rare cancer. Triple-negative breast cancer is a rare cancer. But if you have a rare cancer, you need a predictive value. You know, you need a sensitivity. Actually, I should say you need a specificity, probably 99% for these biomarkers. Otherwise, you will have too many false positives in the population, and you will be doing needless oophorectomies. You'll be taking the ovaries out on perfectly healthy women most of the time to catch a few rare cancers. And this is the challenge in these biomarkers. How do you detect a rare cancer? And so part of what we're trying to do is identify higher risk patient populations so that our positive predictive value is higher. So this is an example of the prognostic ability of the antibody markers. So HE4 and CA-125 are not useful as prognostic biomarkers. And this is sort of an example of how this is a Kaplan-Meier curve over time of these women on the study. These are the women who had the antibodies. These are the women who don't. And this is how it associates independently of outcome, whereas CA125 and HE4 do not associate with outcome. Whether or not this represents a functional immune surveillance, or whether or not this is a independent process, or whether or not this represents something I don't understand, or whether it represents differences in the primary mutations in P53 between those who make antibodies and not, we don't really know. But I think that what we do find is that these are tumor-specific biomarkers with low sensitivity. And I can tell you that we have looked at other pre-diagnostic sample sets, and it's about, before diagnosis, it's on the order of about 15%, 14 to 15% sensitivity for these markers at 97.5% specificity. And they can be detected early. So whether or not they will be useful or not clinically remains to be seen, and is currently undergoing validation in larger scale studies. So that's one marker, and this sort of gives you an idea of the parameters of how these things work. Okay, I'm just going to very briefly talk about that we are doing a fair amount with HPV-associated biomarkers, in particular in head and neck cancers, HPV-associated head and neck cancers. And we study HPV for two reasons. One, it's a viral-associated cancer, and the nice thing is that these are not self-proteins. These are at least foreign proteins, so you might develop more of an immune response to them. And the other beautiful, elegant, or not so beautiful thing about HPV is that it's a small virus. It only has 8 open reading frames. And so with 8 gene products, we can start to think about measuring antibodies to the entire proteome for HPV, and it's HPV-16 that is primarily associated with head and neck cancers. And so when we look at HPV-16 antibodies, we find that if we look at healthy people, we look at partners of patients who have these cancers, who you'd think may actually be getting an immune response in this infectious cancer, or patients with newly diagnosed, untreated head and neck cancers. Actually, oropharyngeal cancers, I should be specific. So these are heavily weighted toward about 70% of these are expected to be HPV positive. And so we find antibodies to different HPV proteins, and this is E1 and this is E2 proteins, and these are E4 and E6 and E7, which have been described, and we get a little bit, not so much, to the coat proteins. But so that these are also potential biomarkers for these cancers, and we can start to look at the complexity of how these immune responses work. But what I can tell you is not everybody gets the same immune response. So some of these patients get antibodies to E1 and E2, and some get antibodies to E6 and E7, and some get antibodies across the board, and I have absolutely no idea why. We have no, the virus itself is probably all identical. There's very minimal sequence variation in HPV. So if it's not the virus, it presumably is something fundamentally different in how people have immune responses to these. And we catch over 70% of these cases in terms of sensitivity, having an antibody to at least one of these proteins. So whether these will be useful markers for these, we're looking at pretty heavily right now. Our signal to noise ratios and specificity of these is really outstanding. I think out of all our markers, it's probably the most useful that we have. And, but it remains to be seen. And they're also prognostic. Wayne Smith and others have shown this. But in the remaining amount of time, I want to talk about how we sort of measure antibodies on a proteome-wide level. We're not really at the proteome-wide level, but we're getting there. So Josh Laber's group has looked at expressing thousands of proteins at a time on slide-based formats. It uses the same type of approach. It's all DNA-based. So you have cDNA that are spotted, and the advantage of this versus other types of protein arrays is you can manipulate that DNA any way you want. So if we want to look at antibodies across the mutated P53s, we can mutate the genes and then look at those. We don't have to purify every single individual protein, which is technically hard to do. So the biorepository that exists at ASU is one of the best in the world. This is Josh calls it the Amazon.com of DNA, and I think it's very similar. I think it's very accurate, actually. One can go online and one can order DNA to your favorite gene or your favorite 10 genes or 10,000 genes in a flexible format so that scientists can use them. And these have been distributed. He has about 160,000 in that biobank right now of a variety of different organisms, about 10,000 full-length human ones out of that set. And they've been distributed to about 33 countries, and so a lot of scientists use them. And they're sort of a very nice little sort of flexible system. And this is what a protein array looks like when you actually express the proteins. This is using an antibody to the tags. And this really just shows that you can get expression across a lot of different proteins and a lot of different types. And the vast majority of proteins do express on the arrays. Whether or not they are structurally intact is not really measured here and is very, very hard to measure. We do know that the majority of the smaller intracellular proteins probably maintain their structure, at least in terms of their ability to bind proteins they're supposed to bind to. But I think that's part of the work. But what we know is we can make these proteins and we can add serum and we can ask whether or not patients make antibodies to any of these individual proteins. And so we did this for breast cancer. We took serum from women with breast cancer, serum from women without breast cancer who were undergoing screening mammography. We took serum from women for validation who are undergoing diagnostic mammography, so they had benign breast disease. So when you want to think about cancer biomarkers, you want to think about, okay, how do they compare to the normal population, but how do they compare against benign disease? Because every cancer has a benign disease counterpart for the most part, except for leukemias. How do they compare? So if you want a biomarker for pancreatic cancer, you want to know how does it compare to pancreatitis or pancreatic benign cysts or other things. So out of this, we screened about 5,000 protein antigens, and we ended up with a 28 antigen biomarker panel. And Garrick was instrumental with our being able to whittle this down. But informatically, and the key of this really is to go from 5,000, if we screened everything on 5,000, our false discovery rates are huge. And so you really have to narrow it down. And so our focus was to do a stepwise process to narrow down the uninformative antigens, to get us out to do a smaller number of samples, to whittle us down to 768, because that is a multiplier of 96, and we have 96 wells per plates, and that's why we picked 768. And so we whittled down with independent sample sets from different locations. So we're trying to control across regional variations and individual sample set variations and things that might happen. So, and then we validate these antigens on an additional independent set of samples. And so we ended up with a 28 antigen biomarker panel. These were primarily to ER-positive cancers, primarily early stage disease. This is kind of what it looks like when you actually look at the intensity of the signals, and you can see these are all run in duplicate antigens, and this particular case has antibodies to a molecule called SF3A1, which is a splice.
3D images for this.
So the 3D images represent the actual signal intensity. Essentially, it's a 3D version of this, which is a 2D version. So you can see the individual spots and the signal intensity within that spot. It's just kind of a cute way to look at it. We were looking at this in particular because it has to do with, in part, how discrete those spots are, to make sure that we weren't getting bleed over and what we call halos, because this is all in solution, so you have the potential for diffusion, and so we really wanted to confirm that they were discrete within here and not sort of a broader area or crossover from another strong signal, and so we were looking at these. So this is kind of what it looks like. This has been published. It was very reassuring, but informative to us that actually our top antigen, which is ATP6AP1, shown there at the top antigen there, these are some of our training and validation set samples. And as you can tell, individual sensitivities are low for these things. But ATP6AP1 was actually a tumor antigen that was initially identified in a GVAX patient, in a post-vaccinated patient who had developed an immune response to autologous tumor in melanoma. And it had been originally published on this. So out of our undirected screen, we ended up with a tumor antigen that had shown up in a vaccinated patient. So this tells us that maybe looking at the vaccines might be useful to identify biomarkers for early detection, as well as potential vaccine targets. So with that in mind, I just want to point out we're doing some of this for triple-negative breast cancer on a sort of a national level. We have been looking at a serous ovarian cancer. We've done the same type of approach. We start with about 5,000 antigens and work our way down. And we have identified several that look promising in terms of biomarkers for serous ovarian cancer, in addition to P53. And you know, at the end of the day, you know, we have markers that they have sort of found their way through discovery in this sort of progressive approach to identifying markers for early detection for cancer. What we know is that p53 is immunodominant for biologic reasons we don't understand. We know that at least p53 antibodies can be detected months prior to diagnosis. We have not assessed that for any of our other biomarkers yet. They are associated with favorable prognosis. HPV antibodies are associated with a favorable prognosis. We don't know yet for our other ovarian markers, or our other breast markers. But I want to come back to the vaccines. Okay, so now that we have a method to be able to measure, and here, remember, we're measuring 5,000 antigens, and now we can measure 10,000 antigens. We haven't even begun to get to the full complexity of the proteome, but we're getting there. Okay. So if one looks at pre- and post-vaccines, we don't really know the best way to say, okay, you developed an antibody response to a given protein post-vaccine. Well, when do you measure it? Do you measure it at 2 months or do you measure it at 10 months? You saw these immune responses that can happen later. You actually get different patterns of immune responses whether you measure early versus late to antibodies. Do you measure ones that are bright? Do you measure ones that go up the most? What are the most important immune responses? Well, we don't know. But you really want to end up ultimately correlating with clinical outcome. And so this is a particular patient. In this case, we were looking at z-scores, and there are many different ways to do this, but in this particular case, we were looking at pre-vaccine and post-vaccine, and you can see here in color a number of different tumor antigens that increased the signal intensity, if you will, across the baseline intensity of these slides after vaccination, and this is 2 months after vaccination for this particular patient. And so if you look at a number of these patients and you say, okay, we're going to use that as our criteria, it needs to be bright, it needs to be z-score greater than 3, and it needs to have increased at least 2-fold from vaccine, and you can use a variety of different categories to whittle these antigens down, if you will. If you look at a melanoma patient who got a vaccine, if you look at 3 different breast cancer patients on this clinical trial got vaccine, these are the antigens that we find. And one of the reassuring things is a number of these antigens have already been identified in the literature as being immunogenic in patients, just melanoma patients walking around, if you will. So the MAGE antigens are commonly used. In fact, MAGE-3 is one that's actually in clinical vaccine trials in lung cancer right now. PDEF is one that we had identified bioinformatically anyway. S100A7 is one that we had published on and had identified bioinformatically, that they were overexpressed at the RNA level in early stage breast cancers by SAGE analysis out of Nellie Polyak's SAGE databases from a number of years ago. Cyclins, P53 showed up actually as induced in one patient, but you can see that there's an overlap between these patients, and there's also unique antigens that show up between these patients that you really need to look on a broad level. But which of these, if any, are associated with the inflammatory responses we see, we don't know yet. This is an example of BCL-XL. So if we do validation studies, you really want to get away from arrays. And I mean, in RNA world, we do quantitative RT-PCR, right, to technically validate things. Here, we have a couple of other approaches. Essentially, these are individual antigens expressed on bead arrays or on slides. And so this is BCL-XL, which was one of the antigens that showed up in this particular patient as immunogenic. Blue and red is pre and post vaccines. You can see the comparison across a number of different other tumor antigens that did not show up. And in yellow is just the protein expression and showing that we're getting protein expression. So again, BCL-XL happens to be in the apoptotic pathway, and that seems to be particularly immunogenic in these patients. So what we learned from this is that protein arrays can be used for multiplex detection of antibodies, that they may be also specific biomarkers for early detection, possibly prognosis, and that we need to sort of move toward the systems immunology approach. And what I want to leave you with is that, you know, in 2000, Hanahan and Weinberg published their classic Hallmarks of Cancer paper, all right, where they identified 6 common pathways that were really critical to the development of cancer: proliferation, evading apoptosis, stabilizing telomeres, angiogenesis, et cetera, and metastasis and invasion. And the interesting and exciting thing is that the next generation of these hallmarks, which were published last year, talk about the 4 additional hallmarks, the emerging hallmarks of cancer. And on the right side are the 2 immune-based markers, because their original hallmarks didn't even address the immune system. And so one of them is avoiding immune destruction. Tumors have to have developed these methods. And the other one is to promote tumor-promoting inflammation. So this yin and yang of the immune response that we're kind of always dealing with, that are really coming out as we think about cancer and moving forward. So with that, this is the group, at least right now. This is inside the Biodesign Institute, actually, at ASU, and this is the motley crew currently, and in my laboratory. And what I want to point out is that a lot of these antibody biomarker work is a long-standing collaboration between myself and Josh over a number of years, both at Harvard and here. GQ, who has done doing a lot of this emerging breast cancer biomarker studies. Garrick has done every single bit of the analyses on these over the years, and a host of other people as we move forward. And with that, I'll take questions. Thanks. That's it. Anyone awake?
So P53 is a transcription factor, and I would bet that it probably regulates its own transcriptional activity. So is it possible that when it gets mutated, it just fails to repress its own transcription, so then it just builds up and leaks out?
It doesn't appear to be a translation effect. It appears to be a degradation effect, at least from what people have looked at. But I'm not certain that that's actually been really nailed down. And the one thing about P53 is that I find interesting, exciting, and challenging is that, as you know, each of those individual mutations are probably not the same. They are probably not the same in terms of biologic effect. They are probably not the same in terms of the pathways and the mutations and the co-pathways that get happen. And they are probably not the same in terms of their functional effect on cancer and clinical outcome. And so as we think about how to think about these cancers, we may end up stopping thinking about this is a breast and this is an ovarian cancer and this is a lung cancer, but this is an R175H mutant cancer. And all of the pathways that go along with that and all the mutations, whether or not it's breast, ovarian, or lung cancers. And presumably, they will have different effects in terms of recruitment, alteration, transcription, not just their own, but other transcriptional elements as well. We know a little bit about this from expression data. We know a little bit about this, but the numbers haven't been there linking tumor genomic sequence in all of its random variation with tumor expression signatures, with DNA, with...
You mean the data isn't there, or that just doesn't correlate?
Well, we haven't had enough samples, again, 500 breast cancers, 25%, 5% of those, you're down to 50 for any given mutation at most. And that's in the national database, so it's really hard to start to analyze that. But I think at this point now we're at a point where we can start to look at those differences between the different mutations. Yeah. Yeah.
Have you gotten to the point where you can tell whether their tumors are metastatic? If these markers are showing metastatic development or non-metastatic?
Yeah, it's actually harder to do than you think, because what you need to ask that question is somebody with the foresight to collect a whole bunch of samples over time in, for example, women with breast cancer who have been treated, who are then walking around and they're fine, and some subset of them, in breast cancer it's a small subset, in ovarian cancer unfortunately it's a larger subset, will develop relapse. And so you have to have serial samples over time in women who relapse and women who don't. It requires bigger biobanks. It requires foresight and money. And there are fewer than you think of those types of biobanks in the country. The early detection biobanks, there are probably 4 in the country, because you have to collect hundreds of thousands of samples in order to find those 9 women with ovarian cancer who go on and develop disease. Head and neck cancer, same incidence rate. Triple negative breast cancer, same incidence rate. It's really hard. We've queried for triple-negative breast cancer, we've queried all the major biobanks in the US and several of them in Europe, and total numbers of triple-negative breast cancer, women who went on to develop triple-negative breast cancer within 2 years of getting a blood draw is less than 100 in sum total of those biobanks. Women's Health Initiative, PLCO, Nurses Health Study, European biobanks. So it's hard to really nail down, are these early detection markers or are they early relapse markers? And one of the challenges with early relapse is you want to have something you can do about it. So in ovarian cancer, CA-125 was approved by the FDA for the detection of early relapse. But the problem is we haven't had anything to do for those women. What do you do if you have an asymptomatic rising biomarker? You have a CA-125 level that's going up. You know this cancer is going to come back, but we do not have any way to cure it at that point. Do we treat then? Do we treat later? Do we watch it? What do we do with it? What it is extremely useful for is enrollment for clinical trials. We know we're worried about these women. You want to be able to do something. You need to be able to figure out what to do. And so I think there will be a real need for biomarkers in this setting. But not that many people have worked on it because it's hard to do.
Karen,
Yeah.
in the GVAC study, you used CA-125 essentially as a surrogate marker. Is there evidence that if you drive down CA-125 that it actually improves prognosis, or is it just this correlative evidence?
So they had CT-associated evidence of disease, not necessarily in that patient, but in another patient. And so they saw some correlation with tumor response. I mean, ultimately, RECIST criteria is based on tumor size, And actually, in immune responses, it's hard to do RECIST criteria because things get worse before they get better. The immune response causes swelling, so everybody looks like they're getting worse. And then things slowly shrink down. So you have to have a strong stomach to do these studies, because both from patients and also from caregivers, because sometimes things look like they're getting worse when they're actually getting better. But you don't know that. There's no way to distinguish that. Really, it's prostate cancer and ovarian cancer primarily that have used biomarkers alone, potentially as surrogate markers of disease burden because of PSA and because of CA-125, because those are the ones that have existed. But in general, most trials are going to use RECIST criteria. You have to measure something somewhere to show that it's actually shrinking. Cool.
All right.
Good.